Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Pemphigus vulgaris under the section of Dermatology. So what is Pemphigus vulgaris? It's an autoimmune disease due to IgG binding to desmosomal component, which is desmoglidin 3, that is present on surface of keratinocytes, and as a result of that, you get discohesion of keratinocyte, which can lead to intraepidermal blisters. As for its epidemiology, it can occur at any age. However, it is most common amongst the ages of 30s and 60s. It particularly affects Ashkenazi Jews, Indo-Asians, and Eastern European populations. As for its signs and symptoms, initially, very frequently, it affects the oral mucosa and it results in painful oral erosions in about 70% of cases. It can sometimes present as painful non-itchy cutaneous erosions. Blisters are less common, however, if they are present, there is a good chance of them to be quite fragile, and when you are putting pressure on a blister, very frequently they end up tearing, and that is called the positive Nikolsky sign. Commonly, it is seen on the upper trunk, scalp, sides of friction such as axilla. As for its investigation, really the history and clinical examination is the key. However, to confirm the diagnosis, you will require to have skin biopsy. And the result of the skin biopsy is very frequently your MRCP MCQ favorites. And what you see on Pemphigus vulgaris is epidermal blisters with IgG on keratinocyte surface, in lesion and also on the unaffected skin. As for your indirect immunofluorescence, it frequently shows serum IgG binding to keratinocyte surfaces. Treatment of it really depends on the severity of the disease. Short-term management is very frequently achieved through oral corticosteroid with steroid-sparing agents such as azathioprine, mycophenolate mofetil, or cyclosporin. In case of severe diseases, you very frequently will need to escalate your therapy to pulse methylprednisolone, plasmapheresis, or IVIG. As for long-term management, oral steroid is really quite common. However, this is very frequently given to the lowest possible dose available. Normally, it is combined with another steroid-sparing agent. The complication of Pemphigus vulgaris, as any other skin condition, is really secondary bacterial infection as a result of skin erosions, which can lead to septicemia. The other key feature in a case of Pemphigus vulgaris would be the difficulty in eating and brushing teeth due to painful oral ulcerations. The prognosis of it is actually quite poor. It is fatal without treatment, and even with treatment, there is about 6% mortality. Okay, let's do some questions then. Question 1. A 45-year-old lady presents with a few weeks history of fragile blisters in her axilla and mouth. She is now struggling to eat and brush her teeth. Examination of the skin shows easily ruptured blisters on her trunk and axillae. Given the likely diagnosis, what is the most likely finding on skin biopsy? So this requires sort of a two-step verification of your knowledge. Hopefully by reading the clinical vignette, you have realized that this is classically describing a case of Pemphigus vulgaris. You've got a middle-aged patient who's got a few weeks history of fragile blisters in the friction area such as axillae, and more importantly, it's also affecting her mouth, leading to struggle with eating and brushing teeth. So hopefully by getting the diagnosis of pemphigus vulgaris, you would have realized that your options are a bit more clearer. Given the likely diagnosis, what is the most likely finding on skin biopsy? The options are A. Neutrophilic infiltrates, B. Blister at dermoepidermal junction, C. Intraepidermal blisters, D. IgA against the dermoepidermal junction, EC4 along the dermoepidermal junction. And if you recall from our discussion earlier, if you have gathered that this is a classic case of pemphigus vulgaris, you would hopefully realize that the correct option is going to be option C, which is intraepidermal blisters. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.